Welcome everybody to the first of our CHS Renal webinar series for GPs. My name's Anne-Marie Swoboda. I'm a GP and I'm the Medical Director of the GP Liaison Unit at Canberra Health Services. So before we begin this evening's session, we wish to acknowledge the traditional custodians of the land on which we're meeting, the Ngunnawal people. We wish to acknowledge and respect their continuing culture and the contribution they make to the life of this city and this region. And we pay our respects to their elders past, present and emerging. And we'd also like to acknowledge any Aboriginal and Torres Strait Islander people who are joining us for today's session. So just a tiny bit of housekeeping, because you should all be on mute, but feel free to interact with us throughout the webinar. You can use the QA function at the bottom of your screen. I'll be monitoring your comments and your questions, and we'll have an opportunity to answer all of your questions at the end of the presentation. So this webinar series is the first of three, or hopefully four, on kidney health. And this is a really important topic for GPs. Kidney disease is very prevalent in our adult population and is certainly on the rise. And as GPs, we know that renal disease is often silent and that we play a crucial role in the early detection and management of kidney disease. So this evening, we're starting off with two topics, hypertension and acute kidney injury. It's my pleasure to introduce Dr. Tom Lee-Henry. So Tom's a renal physician who joined Canberra Health Services last year, is that correct?
Most recently.
Yeah, very recently. And he's a clinical scientist and a McCusker Research Fellow at the ANU. And he obtained his degree in Queensland before undertaking vocational training in Townsville, Canberra and Newcastle. And he currently leads several education initiatives at Canberra Hospital. So I'll give it to you, Tom, to take it away.
All right. Okay, so as Anne-Marie said, topics today are hypertension and AKI. It's got a bit of a focus on hypertension, and we cover some AKI at the end. We will be doing a CKD topic later on as well. And if there's any outstanding issues, we can revisit those from the AKI perspective then. Just giving a quick overview, we're going to go through five cases just to highlight different issues in the management of patients with hypertension. And then once we've done that, we'll go through medication and acute kidney injury at the end. So this is a quote from 2007. I think it's actually really very relevant because one of the difficulties that we often have when we're treating people with blood pressure is this sort of therapeutic nihilism. You know, we can reduce someone's blood pressure, but do we actually cause them significant benefit? And certainly, are we contributing overall to societal health? And really, I think it is still true that controlling blood pressure with medication is an exceptionally cost-effective way to reduce not just cardiovascular morbidity and mortality, but also all-cause mortality in general. And there's a lot of evidence that's come out to support that. So just a background for hypertension. Approximately a third of the Australian adult population is hypertensive. And actually 23% of those have either uncontrolled, so they're on treatment and they've not got their blood pressure to target, or untreated hypertension. And this is increasingly true as people age. So almost half of our 85-year-olds and above are hypertensive. Despite all this, only about 11.5% of people who are of the Australian population self-report as being hypertensive. So there's a disconnect here between the burden of the disease and people recognizing it as an issue that they have. And this actually can make treatment quite difficult because often hypertension is asymptomatic, but we know it in the long term and certainly in the medium term, it can cause significant damage and actually complicate the health of these people. So lack of recognition is one of the underlying problems that drives some of the outcomes. Hypertension is a major cause of chronic organ damage. So it contributes directly to the development of atherosclerosis through damage to the vascular endothelium. It contributes directly to congestive cardiac failure and diastolic dysfunction through increased afterload. And it also has, from my perspective, is really important in terms of chronic kidney disease. So Hypertension causes increased intraglomerular pressure, which over time causes damage to the intrinsic cells of the glomerulus and causes essentially scarring over time. And it remains the third leading cause in Australia of people requiring hemodialysis. So it's actually still a major ongoing issue for us. In terms of what counts as hypertension, we still really work off the JNC, the Joint National Committee on Hypertension's definition, and that's most recently updated in 2014 with the JNC8, where normal blood pressure is considered less than 120 on 80, and hypertension is considered above 140 on 90, with various stages above that going up essentially by 20 systolic for each one. And despite all this evidence that hypertension is really bad for people, and it contributes significantly to societal ill health and costs to the healthcare system, we actually really don't understand what causes essential hypertension in the majority of people. We know there's a genetic component. Essential hypertension is more likely to happen to you if you have a family member with the same condition. But we still don't really understand how all these mechanisms play out. And that means it's harder to monitor, harder to predict who's going to have problems, and also means we're potentially missing therapeutic strategies as well. So the other thing as well is I remember as a medical student thinking, well, what do we really need to do? Like, what do we need to take someone's blood pressure down? If it's 160, do we need to get it to 120 to actually see benefit? And importantly, really small reductions in blood pressure have significant clinical outcomes. And so what I've shown you here is one study from 2016, which showed that if you reduce systolic blood pressure by 10 millimeters of mercury, which you can achieve essentially with single antihypertensive therapy in the majority of people, it has really significant outcomes. So you're getting a 25% relative risk reduction for cardiovascular events and stroke, heart failure. And you can see kidney disease is really the only one that doesn't cross the line of significance there. But we're talking about a 10 millimeter reduction in systolic blood pressure, which is really achievable, and the outcomes can be really important. So you can see all-cause mortality is reduced, so death from any cause if we reduce it, and this is only on the 10 millimeters of reduction. Interestingly, a second study in 2022 showed that if you even reduced systolic blood pressure by 5 millimeters of mercury, there was really significant improvements still in cardiovascular disease. And this almost didn't matter what your systolic blood pressure was. So across the range from if your systolic blood pressure started at 170, all the way down to, in fact, if it was already even less than 120 and you could tolerate further reduction, there was still this marked improvement in your cardiovascular risk of death. So that kind of brings us to case one. So these are all generally made up. So there's no real patient confidentiality issues here. They're kind of sort of dragged up, I guess, from a number of different people that I've seen over the years. And so the case one is Mr. RM, as a 58-year-old male, and this is a routine checkup. No significant past medical history, but on assessment today, the blood pressure is 157 on 91, so stage 1 hypertension, on systolic at least. Pulse rates normal and regular, and there's actually no significant, there's no differential blood pressure on the other side, suggesting that there's no local vascular issue contributing to this. So what's our approach to this? This is something that we see a lot in the renal clinics, people who are recently diagnosed with hypertension. And so one of the first things we have to do is we need to make sure that we've got the diagnosis of hypertension correct. And so this is a summary taken from the Kidney Health, the Heart Foundation guidelines on the management of hypertension. And it takes you through the steps of how do you take someone who has a single high blood pressure reading and how do you decide that actually they're hypertensive or not. And actually it's quite complex. Patient needs to be seated and relaxed. And if you delve into these guidelines further, taking blood pressure in the guidelines is quite a complex exercise. You should get initially both arms, and you need to make sure that you're not having any errors that can lead to abnormalities. So making sure the clothing's appropriate for the test. You're not doing it over a thick jumper or something like that. But the most important bit is it needs to be taken on a couple of occasions, at least 1 week apart. So a single one-off reading strictly wouldn't be considered hypertension. The likelihood that this person's going to come back in a week's time and they're not going to have hypertension is pretty low, though, given it's, almost touching 160 systolic. So one of the things we need to do is get them back to recheck. It's not so high at the moment that we would need to get after this. And so as you can see here, this is kind of talking through that JNC8 classification. This person would have grade 1 hypertension. And really, we don't have a lot of other information, but it suggests there's no other significant risk factors here. So we wouldn't have to delve in straight away to treatment anyway. So we do have time to sort this one out and work out whether actually we do need to start treatment. And so assessing the patient with hypertension, sorry, there's a little bit of busyness here on the slide. There we go. So relevant background history, because really what we're talking about here is someone who we suspect is going to be hypertensive. Are there reversible factors that we can control without pharmacotherapy to reduce their blood pressure? But in this person, a non-pharmacological approach probably would be reasonable in the first instance. And so in terms of relevant history, you want to make sure that, look at their diet, particularly where we're interested in sodium, but we'll get into dietary change in a little bit of time. Do they exercise? Either cardiovascular or resistance training both have important benefits for blood pressure. Are they smoking? Still about 10% of Australians smoke, and that's a contributing issue. What is their alcohol intake, and can that be reduced? Sodium we've kind of covered with diet a little bit, and caffeine. Do they drink too much coffee like I do? And is that something that maybe we could reduce? And then the other thing we need to think about is we've kind of taken it for granted that this guy's got no other issues because that's what's been given in the case. But we need to do an assessment and make sure we don't have evidence of end organ damage. So simple things that we can do. So an ECG to make sure there's no left ventricular hypertrophy. We might also pick up other things like atrial fibrillation in the setting of someone who's got a little bit of diastolic dysfunction perhaps already. We do standard set of blood tests, really from make sure we're not seeing evidence of kidney damage, so GFR and a serum creatinine in the first instance. We look at their other cardiovascular risk factors. Does this person have dyslipidemia? Are they diabetic or pre-diabetic? And so we would screen for those things. And then the other thing that's important, particularly personally from a renal perspective, is to send off some urine. And we're looking at two important things here. One is protein. So urinary protein is important from a cardiovascular risk perspective. So we know that independent of its impact on chronic kidney disease, albuminuria is actually a risk factor of endothelial dysfunction and the risk of cardiovascular disease. So that kind of helps us categorize these guys. And the other side is, do they have hematuria? Is this a presentation of a chronic or a low-grade glomerulonephritis? And this person's going to have an active urinary sediment with microscopic hematuria. The other thing we need to do is assess cardiovascular risk. And I think the best way to do that from my perspective, the one that I personally use, is to use CVD, the CVD calculator. That's the Australian version for that. If you simply Google CVD check, you bring up the website and you simply enter the patient's details, and it gives them a 5-year risk for a cardiovascular endpoint, and it also gives them ideas around things they can do in terms of dietary modification and things like that. All these things always have to check the fundi. I haven't checked the fundi in a patient now since the clinical exam. I'm not very good at it anymore, and I don't actually generally recommend people do this unless they're comfortable with doing it. So what should we be targeting for this guy, presuming he comes back with hypertension? And this is actually a more difficult question to answer than it should be. What we know, if we look at the American system, is it really doesn't depend what your comorbid status is. The blood pressure goal for almost everyone in the US is less than 130 systolic and targeting less than 80 diastolic, except perhaps in the older person. In Europe, things are slightly similar, but they're giving a little bit more tightness around that. So they're targeting a systolic blood pressure here of 120 to 129. And where it's poorly tolerated, then essentially you get it as low as you can, which is probably a reasonable principle. In Australia, we've got a little bit more granularity here. So what they say is really we should target everyone to a target of less than 140 on 90, so no longer hypertensive. And if we can get it lower and they tolerate it, then we should. And so particularly if you've got cardiovascular disease, we should be targeting a systolic less than 120. It's the only time you might not do that is when you're balancing that against people who are at increased risk of falls or AKI. But even then, there's wiggle room there to trial for that. And the reason for that is a large number of trials have come out. And this is the only figure like this in here, I think. So there was quite a large number of, so 2 major trials that came out, and one of which kind of had 2 parts to it. And one of the major trials that's changed a lot of blood pressure targets for many groups of people is the SPRINT trial, which came out in the New England Journal in 2015. This was a massive study, looked at thousands and thousands of American patients and looked at a standard therapy where they were targeting that less than 140 on 90, or an intensive therapy where they're actually targeting less than 120 on 80. Now, the interesting thing to know about that is that on average, they never hit that intensive target. So the median systolic blood pressure for the intensive treatment group was about 125 systolic. So even though we target less than 120 on 80, even in the SPRINT trial, we didn't actually get there. But what the SPRINT trial showed was that in all these groups that had previously been excluded or only included in a small number of trials, like people over the age of 75 and people with advanced chronic kidney disease, was that really for many of these people, aggressive blood pressure management was actually better in terms of not just cardiovascular outcomes, but actually total morbidity from any cause. And so this made us rethink our blood pressure targets, because before the SPRINT trial, we were talking about in certain groups of people targeting less than 150 systolic. But this data suggests that even in the elderly, aggressive blood pressure targets may have benefit. And we'll come back to that. The other thing I've just popped up here is the Australian guidelines looking at lifestyle modification. Because I think some of this stuff is, it's worth having a think about what's actually recommended. So physical activity, they're talking about not just cardiovascular activity. So when I think of my patients and giving them advice around physical activity, I'm kind of thinking, 20 to 30 minutes of sort of, maybe moderate activity a few times a week, really thinking of cardiovascular activity. But it actually suggests also specifically they should be doing muscle strengthening exercises, so resistance training as well. And that's with more data coming out around the role of resistance training in lowering blood pressure. It's likely to start to see that on a few more guidelines. Weight control obviously is important, although obviously very, very difficult to do for the majority of people, although that may change with pharmacotherapy in the near future. And then dietary stuff. So it's really hard, isn't it? Because kind of everyone knows what a good diet is, but not many people can stick to it. But reducing, optimizing diet can actually have really profound effects. In fact, as we'll touch on in a mo, if you follow some of the dietary guidelines around hypertension, and then you throw in alcohol reduction, and you also reduce your salt, you can reduce your systolic blood pressure almost 15 millimeters of mercury. And there's no drug on the market that will do that. So it's pretty profound potentially. Smoking cessation makes sense. No one should be smoking ideally. And then alcohol, we don't really have safe guidelines about intake now, but certainly modification to sort of less than 2 standard drinks at a time, and ideally abstinence if possible, is probably the recommendation these days. And this kind of just reiterates that actually, that but looking at the over 65s, it doesn't really matter how old you are. We should be getting out there and doing that sort of 30 minutes most days, and trying to make that a regular thing, maybe 5 days a week. So how do we decide to treat? Actually, decision to treat is a combination of absolute blood pressure and the cardiovascular risk. Anyone who's high cardiovascular risk based on the CVD check, so more than 15% cardiovascular risk. So if you've got advanced chronic kidney disease, for example, you're immediately high risk. So then we need to start treatment immediately. So many of the patients that we see, actually, we do need to start treatment much earlier. If you're at moderate cardiovascular risk, then it depends on, where your blood pressure is. So if your blood pressure is consistently very high, then we're going to start treatment. Equally, if you have an Aboriginal or Torres Strait Islander background, that's going to drive us towards treatment too, because the risk is inherently higher for Indigenous Australians. And if you've got a family history of early cardiovascular disease, that is going to drive us towards treating sooner as well. If you don't meet those guidelines, we had this opportunity to try and institute lifestyle modification and then follow up around 6 months. If you're low cardiovascular risk, only if your blood pressure is consistently high are we really going to drive hard after this and start therapy. Otherwise, again, this gives us this window which we can trial lifestyle modification. So this is the same guidelines, but it's looking around now cardiovascular risk specifically, and essentially saying what we should be target. And so if we have systolics over 160, then we should be targeting you really, even if you've got a relatively sort of moderate to low cardiovascular risk. If it's high, then we need to start pushing as soon as it's over 140. And so that's kind of what I said at the start, was that the decision to treat is that combination of cardiovascular disease and your absolute blood pressure. If your cardiovascular disease is high, we're going to tolerate a lower starting blood pressure before we start starting therapy. Yes. Sorry, I hope if there's a cleaner outside, hopefully it's not coming through on the mic. All right. And so what are we going to do for these guys? What's the initial therapy? So the recommendations around this have changed since I started practice. So initially, we start with a low to moderate dose of a single first-line drug, and we'll go through what those are. And if they don't tolerate it, we swap to a low to moderate dose of a different one till we find one that they do tolerate. If we don't have control at that point, what we used to do was maximize the dose of one medication and then shift to another. I still do that, in a reasonable number of people, particularly when I'm targeting a particular outcome. For example, someone who's got proteinuria kidney disease, I will start them on an ACE inhibitor or an ARB, and then I will push that up, not only to blood pressure target, because I'm also trying to reduce their proteinuria. But for the person who's just got general hypertension and not a lot of other risk factors, the suggestion is actually we add a second agent at low to moderate dose. And the argument here is that we minimize the side effects of both medications by keeping them at moderate dose, and actually we might have a more than additive effect in terms of blood pressure control. And then if we still don't have control, then we push up the dose of one. If they're on a diuretic as part of this regimen, we push up the other agent. Otherwise, it actually doesn't matter. We choose based on other indications. And so the choice of first agent, I use a lot of ACE inhibitors and ARBs because I see a lot of patients with diabetes. I see a lot of patients with proteinuria kidney disease, and there's good evidence for these as well. If your patient has a history of heart failure or they've had a stroke, there's also evidence as well that an ACE inhibitor or an ARB is probably your best line starting agent. Beta blockers, many guidelines are moving away from using these as a first-line agent, but if in patients who have symptomatic coronary artery disease, they're going to probably see beta blockers used much earlier for managing their symptomatic angina. Otherwise, thiazides are generally reasonably well tolerated. Perhaps in the elderly, I'd be a little bit more cautious around hyponatremia. But otherwise, there's potential risks around diabetes and diabetic control, but they're generally appropriate for most people. So there's a couple of questions to consider at this point. I'll sort of ask them potentially rhetorically even. So what's the best way, what's the one time of day to measure blood pressure? And so the answer to this is in terms of the optimal way, a 24-hour ambulatory blood pressure monitor is the best way. It gives us the best actual understanding of what someone's average blood pressure is, and it takes out of the arguments for these questions around white coat hypertension. It helps us to uncover masked hypertension as well, where people actually are normotensive or close to normotensive in the office, but actually are reasonably hypertensive outside at times. In terms of the time of day, actually a range of times is ideal, so that we can start to get a picture. If we're doing it intermittently with home blood pressure monitoring or at different times with an office blood pressure, getting it across different times of the day can also be helpful to see if particularly some people are particularly hypertensive in the morning. For example, people with obstructive sleep apnea can be more hypertensive early on. And so we don't want to miss those times. So spreading it out is also good. I tell patients when I'm asking them to journal blood pressure, to do it, ideally for a week if possible, a few times a day, or at least if they're going to be doing it once a day, to try and vary that. So when is ambulatory blood pressure monitoring indicated or useful? So the guidelines recommend that this is useful for someone who you think might have white coat hypertension, to prove that it's white coat hypertension and not sustained hypertension, to decide whether someone is actually hypertensive or not, whether if they're coming in and they're a bit borderline in terms of blood pressure. By the time you get that 24-hour reading, you can get a much clearer outcome. If we're investigating people for resistant hypertension, so we've got them on 3-agent therapy, and their blood pressures haven't improved, and this is a reasonable opportunity to have a look at that as well. And also, if we're worried about potentially they have other sort of secondary causes of hypertension, sometimes having nocturnal blood pressure monitoring can be useful. So, move on to case 2. Case 2 is when Mr. RM comes back. He's now persistently hypertensive because his blood pressure is high again the next time, and he's been journaling it at home. He's done otherwise well, but we've started him on some indapamide, which in terms of thiazide diuretics, hydrochlorothiazide is the most ubiquitously available, but it's actually the one that I use least because it has a relatively short half-life. And so it means you don't get that sort of 24-hour blood pressure control. Indapamide has this modified release option, which is beneficial potentially, and chlorthalidone is the other one, which has a quite long half-life, and some of us use quite a bit. So the approach here in someone who's on single-agent therapy but still hypertensive. So before we kind of get into where we go, we'll kind of talk about options. So we all remember that blood pressure is a combination of total peripheral vascular resistance, the intravascular volume, and the cardiac output, which is made up of stroke volume and heart rate. So in terms of the kidney, we can manage intravascular volume. We can reduce it with diuretics. Interestingly, their long-term effect is actually more reducing total peripheral vascular resistance, but I find it convenient to think of them as an intravascular volume depleter. So we can target volume state with those. We can target cardiac output, particularly through beta blockade, but also non-dihydropyridine calcium channel blockers. And I'm only covering the sort of commonly used antihypertensives here, I should say. The other thing that we can do is we can look at the downstream effects that the kidney does to drive blood pressure, such as we can potentially inhibit renin. It says juxtaglomerular apparatus. It should say juxtaglomerular apparatus. So we can use renin inhibitors to prevent the activation of angiotensinogen to angiotensin 1. And we can downstream control the effect of angiotensin 2, either through ACE inhibitors, blocking its production, or angiotensin receptor blockers, blocking its effect. And you can see why ACE inhibitors and ARBs are such potentially potent antihypertensives. They have a direct effect on vascular vasoconstriction in the arteries at the top right. They actually feed back directly onto the kidney and increase sodium and water retention. They also drive an aldosterone release from the adrenal cortex, which further drives sodium and water retention. And then the last way we can target the arterial vasoconstriction is through dihydropyridine calcium channel blockers, such as amlodipine. So, based on this, if we back to this bit here where we've got them on a single drug, it's at standard therapy. It's not really low or moderate. It's not really high. The next step is we need to add something else. And so, again, this is kind of pointing to what our target should be. This guy doesn't have any reason why we shouldn't be going aggressively after his blood pressure. So I would be targeting him. Targeting for less than 120 systolic, but if I had him in the 120s, I'd be pretty happy with that as a less than 130. Because I think sometimes we're talking about potentially diminishing gains. Although if you can safely bring someone's blood pressure less than 120, there is probably benefit. And so what potentially would we might like to add? So if we've gone ACE inhibitor or ARB to start with, really we can go with anything. And it really, again, kind of talks about what are the things we're trying to manage. So if you're adding a calcium channel blocker, that may be potentially useful for people who are diabetic, for example. Thiazide diuretics, you can talk about these post-heart failure or post-stroke. In terms of heart failure, they're not like a furosemide. You're not going to get that significant extravascular water reduction. So I don't think of them necessarily in that way for someone with symptomatic heart failure. And for beta blockade, again, we're talking about people with symptomatic coronary artery disease. We don't normally see people start on beta blockade, but if they did, then we've got other options. The dihydropyridine calcium channel blocker may also increase blood flow by vasodilating the arteries. And then the thing that we don't really generally recommend is thiazide versus thiazide diuretic with beta blockade. And again, this is potentially around this issue with development of diabetes and also the resistance to the symptoms of hypoglycemia. But generally, we can pick anything we like. There are a couple of options we don't want to go with, diltiazem and beta blockade. So a direct cardiac acting calcium channel blocker in diltiazem. With beta blockade, there's an increased risk of complete heart block and bradycardia. We don't recommend ACE inhibitors and ARBs together anymore. Some people do use them with extreme caution, but there's a significant risk of acute kidney injury and hyperkalemia. There is some potential theoretical benefit, but for my perspective on this is that the risks outweigh that. So I don't have these two together, particularly now that we've got other things that we can use for proteinuria kidney disease. Other combinations. So at the top you can see the second one down, ACE inhibitors and ARBs with potassium-sparing diuretics. This is a hyperkalemia issue again. So particularly if you're looking at someone with like spironolactone, it's very uncommon to see some of the other potassium-sparing diuretics these days, but spironolactone is the commonly used one. And then again, verapamil and diltiazem, it's the same. It's verapamil and beta blocker is the same problem as with diltiazem. So we try and stay away from those. And so questions about this person, or I guess in general, is what do I do about the patient with white coat hypertension? And that's actually a really complicated question to answer. So white coat hypertension you'd expect is not an issue because by definition, the patient is hypertensive only when they're seeing you. So unless you live with them, it shouldn't be an issue. So, but unfortunately, it's not that simple because it is actually still associated with increased risk of morbidity and mortality, controversially, because there are some studies that suggest this isn't so. But when we look at the literature as a whole, it does suggest actually there's about 50% increased risk of morbidity and mortality next compared to someone who's normotensive. And that bothers me because we can't really be treating these guys for high blood pressure because most of the time they're not actually hypertensive. And so it becomes more one of these ones about monitoring them. And the rationale here for this increased risk is the thought is that they are more likely to be hypertensive when they're seeing us because they have risk factors for development of hypertension down the track. Maybe they've got vascular stiffness. So when they get a bit nervous, that blood pressure is more likely to rise. And so it becomes something which triggers in my mind, hey, I'm not necessarily going to start treating this guy, but I do need to start monitoring them. And then when should I treat? Really, the evidence and the guidance around this is when they become consistently hypertensive. There have been studies looking at treating white coat hypertensive people to see if outcomes change, but unfortunately, the evidence isn't strong enough to really suggest that. And then this one, which is how much does lifestyle dietary changes make to improve blood pressure control? And the answer is profound. So Again, if you go with the DASH diet, DASH, or capitals, which essentially is high fruit, high vegetables, lean meats, high fiber diet, that significantly reduces your blood pressure. And again, if you throw in on top a low salt diet and cutting down alcohol, that, like I said before, is more impressive than any antihypertensive that we've got. If you reduce weight, your blood pressure goes down by about a millimeter of mercury systolic per kilo of blood pressure that you lose. So weight reduction is really important. And similarly, taking up cardiovascular or resistance exercise, either one of those alone, you're looking at maybe a 3 millimeter of mercury difference in blood pressure reduction. So there's a whole lot of actually really important things people can do, because for the majority of us, we are relatively inactive. We do eat unhealthily. Some of us still smoke. And if we start to cut those things out, what we can find is maybe we don't need antihypertensive therapy, or maybe we can at least delay it, which from a personal perspective, I would find valuable. So case 3. So this is a new patient now. We're introducing Miss MP, a 31-year-old female, and she's recently come into the area, and she was just presented for a routine refill of her oral contraceptive pill. And unbeknownst to her, she is hypertensive this time. This is, as far as she's aware, never happened before, but her ECG shows evidence of left ventricular hypertrophy. She has a follow-up echo down the track that confirms LVH, and actually she's got early diastolic dysfunction. And so the approach here is different to the first patient, even though this one's considerably younger. And the approach is different because this person is showing evidence of end organ damage. So there's cardiovascular complications at the age of 31 in this person. And unfortunately, this isn't as uncommon as we'd like. And so the other question we need to ask for a 31-year-old lady who's got end organ damage from hypertension is this a primary essential hypertension? And we don't really know what's caused it. And if you're betting statistically, then yeah, most people do have primary hypertension, and we don't find a secondary cause. And this is normally associated with increasing age. So when we see it in a younger person, we're a little bit suspicious. Again, there's this genetic component that we poorly understand. And again, there's this concept of sodium intake. So reducing sodium intake in the diet is essentially like taking a diuretic. The diuretic strips the body of sodium, and not putting it in the first place also reduces your whole body sodium load, which then reduces your intravascular volume. Doing both together, actually, just out of interest, is significantly better as well. And then secondary hypertension. So secondary hypertension is where we actually have an identifiable cause. This person has an underlying disease process that's causing their hypertension. And if we can manage that disease process, we can stop their hypertension being an issue in some of those cases. And so one of those issues is kidney disease. You can see the kidney sits central to a lot of blood pressure management pathways. And when the kidney function is impaired, or in some particular instances like glomerulonephritis, hypertension is actually a core part of the disease process. And so if we can manage those issues, then hopefully we can control blood pressure a bit better. And then we're looking at the adrenal glands, excessive release of corticosteroids, or aldosterone, so Conn syndrome, primary hyperaldosteronism, which is surgically treatable. And in the meantime, we can put someone who's got excessive aldosterone on spironolactone and very, very well control their blood pressure while they wait for theatre. And then we're also thinking about things like pheochromocytoma, which the screening for which now suggests we should probably see symptoms or intermittent blood pressure spikes. But I screen everyone who's young for Cushing's, Conn's, and pheochromocytoma. The other things we need to consider are renal artery stenosis in a young female. Actually, this could be fibromuscular dysplasia. So we just certainly need to think about those sort of things. In an older person, it's going to be arteriosclerotic vascular disease. Preeclampsia in the pregnant person, hopefully we would know about that. And then these kind of rarer things, thyrotoxicosis, doesn't normally cause super high blood pressure, but it certainly can be high. Raised intracranial pressure, hopefully that's not the first presentation that we're seeing of that. And so we need to think about these things when we're seeing a younger person present through the clinics. Shall I go back to that for 1 second? So from that side of things, for the young person that comes in, my approach is to look for adrenal causes. I do a renin, aldosterone, cortisol, and I do a serum-free metanephrines as a screen for pheochromocytoma. And in terms of renal disease, if I don't screen them immediately with a renal Doppler, if they have renovascular disease as the cause of their hypertension, their renin will be high. And so when they come back with high renin, then I'm going to think, okay, where is the renin coming from? They could have the exceptionally rare tumor-releasing renin, or probably they're going to have some sort of flow limitation to the kidney causing renin release. And that's when I'll go back and I'll do the renal artery Doppler.
What are those tests again?
So, sorry, those tests again. So,
renin?
So renin and aldosterone. So that'll tell us about, renin will tell us about essentially renal perfusion. There are rarer things that can cause it to rise. Look at aldosterone as a downstream signaling from renin, but also potentially we might have primary hyperaldosteronism. We'll do cortisol to make sure they haven't got Cushing's disease. And then for my pheochromocytoma screen, metanephrines. Yeah. I do get paranoid. I do a set of TFTs as well, but probably the evidence around that's unlikely if they haven't got other features that make you suspicious. The other thing about the renal Doppler, the other thing that will make me go there sooner is if the person's been referred across because they've got no blood pressure issues, someone's started an ACE inhibitor, an ARB, which would be a great choice generally speaking, and suddenly their renal function's dropped, then I'm going to be more suspicious as well. And I'm probably going to go for that renal Doppler a little bit sooner.
So would you order those tests on every person?
So
or only the younger person, like in this particular case?
I do it only in the younger person. If they're older, then unless they've got other features that make me concerned. So if they're, for example, they're hyperglycemic, I'll start to consider maybe I should be looking for Cushing's. If they've got renal dysfunction, then I might consider driving after that renal artery stenosis. But generally speaking, I kind of reserve those for the young. Yeah. So case 4. So this is resistant hypertension. And we'll get into the definition of that in a mo. So 2 years on, Mr. RM. So this is our first patient again, sorry. We're cycling back. He's still having trouble with his blood pressure. His blood pressure is now 165 on 95 millimeters of mercury. And he's on maximal dose of amlodipine, ramipril, and a reasonable dose of chlorthalidone. I thought I'd remove that, sorry. Of a thiazide diuretic. So he's on three agent therapy at this point, and he's still got reasonably poor blood pressure control. We've gone and done a 24-hour ambulatory blood pressure monitor to make sure we're not treating white hypertension. And this confirms that actually he is as hypertensive as he seems. And so what's our approach to this? It's tricky, isn't it? Because I always worry about these guys. I hate prescribing polypharmacy, and I do a lot of it. You're seeing someone here, you've got 3-agent therapy. Every time you add something, the risk of them having adverse effects increases. And so I do get a little bit worried, but we've done actually a reasonable job here trying to get control. So before we get into what we'll do, we'll just kind of it was a quick aside to look at how we might look at this guy's blood pressure, because we've gone the 24-hour ambulatory blood pressure monitor, and that's a very good test. And I do use it quite a lot. Probably maybe once every second clinic, I'll send someone off to get it done, I suspect. The office blood pressure is a great screen, but it's only a snapshot, and it's really confounded by the fact that up to 40% of people's blood pressure is going to be higher when they're sitting next to us in the clinic. So the other options are, do we do home blood pressure monitoring, so to get the patient to check their own blood pressure at home, or 24-hour ambulatory blood pressure monitoring? And those obviously have that reduced risk of white coat hypertension, but they have this high risk of masked hypertension, where actually patient's hypertensive, but we don't see it. And so I see this when you've got that suspicious patient who comes back and all their blood pressure tests were from yesterday and they're all very, very, very good. But their blood pressure next to you is 170 something systolic. And so sometimes it's an issue with the device. It's a poorly calibrated device, or it's been poorly used. Sometimes people just don't want to do it, and they don't want to tell you that. So the problem is that's kind of drives to is you need a standardized method. So you need a validated blood pressure device, and actually many of the ones even sold in pharmacies are not validated. And you need to do this. The suggestion is twice a day, morning and night, for 7 days. And really, my opinion about this is only for those who are independent and who are motivated, because I struggle taking medication twice a day. The idea that you're going to get someone who might struggle to take meds twice a day to do blood pressures twice a day is honestly laughable. They do exist, but if you find that some of your patients aren't willing to do that, then a 24-hour blood pressure monitor is actually probably a better test overall. It's just not as convenient. So what the definition for resistant hypertension is someone who's by definition hypertensive, more than 140 on 90, that is still uncontrolled on 24-hour blood pressure monitor, which guidance suggests is required for diagnosis. You have confirmed compliance. I'm not sure how one does that. I just generally ask. You can never be 100% sure. And they're on a 3-agent regimen. This is fascinating because this is actually quite a lot more common than we thought. If you look at the literature, it's somewhere between 10 and 35%, but most of that is what we term pseudo-resistant hypertension. It means the patient tells me they take their meds, but actually they probably don't. Maybe a best guesstimate is close to 5% of patients with treated hypertension. That's still a lot of people when you think that there's millions of people in Australia who are hypertensive. We're talking about potentially, tens of thousands, maybe even 100,000 people who are who have resistant hypertension. And importantly, this is a bad outcome. So unsurprisingly, if you have blood pressure that's very poorly controlled with multiple agents, your morbidity and mortality go up. And this is a combination of the extent of your blood pressure issue in terms of how high your blood pressure is, but also realistically the time that you're going to be exposed to that, because it takes a long time to implement 3 antihypertensives, maximize their doses, and decide they haven't worked. It's not something that we can do in a month or two, generally. And so this is from this paper, they suggested this approach, which is if you've got someone who's apparently got treatment-resistant hypertension or resistant hypertension, we exclude white coat hypertension. That the best way to do that is the 24-hour ambulatory blood pressure monitor. We exclude non-adherence, which is difficult to truly exclude, but we do our best. And then we end up with true resistant hypertension. We then look at modifiable risk factors. So weight loss, as the obese patient, weight loss is one of these things. Sleep apnea syndrome is actually a potentially reversible risk factor for this too. So for those patients who have symptom burden, there's suggested potentially of this, they should be have a sleep study. We need to, again, do those other things that we know that we can control, drop dietary sodium. And if they've got poorly controlled diabetes mellitus, then getting that better controlled is also going to be beneficial. But then the other things we can't control, older age, male, and a higher blood pressure at diagnosis when they first came to a recognition are things that we can't control. And so the approach to this is once we've excluded pseudo-resistant hypertension, we've optimized therapy, and then we've assessed that we've got rid of our, we've ticked off our potential secondary causes of resistant hypertension, and they still have uncontrolled blood pressure. Then if you see here, I flick this up because it kind of says if you haven't got them to target after 3 therapies, you can keep pushing on, which actually we'll talk about right now. But the other thing is actually it's not an unreasonable place to seek specialist advice as well, because this person may also need some secondary screening as well. And so how do we manage this? Blood pressure, so the standard stuff, lifestyle stuff, which we probably already implemented, hopefully, but we can reiterate that, optimize the doses, and then we add a 4th drug, and that should be spironolactone. I'll talk about that on the next slide. And then there are potential interventional treatments, but generally speaking, they're not recommended. So we're talking about renal denervation and things like that. The data around supporting those is not strong enough that we would sort of take people down that route, certainly not in Australia. So let's talk about spironolactone, because spironolactone actually has really good evidence from this Lancet study in 2015 as being really probably the best thing that we've got for managing resistant hypertension. So you can see in this study, we had a few thousand people here. These were people who were optimized on 3-agent therapy at the highest tolerated doses. They still were hypertensive, and then they were put onto a cycle of either spironolactone, doxazosin, which is similar to prazosin, and bisoprolol. They started at a relatively low dose, and they were brought up to a higher dose over the course of 6 weeks, and then they had another 6 weeks at that higher therapy. And what you can see here is there's really quite a significant reduction in the spironolactone group relative to all the other groups, including those who had those other additional 4th agents added. The rationale here, which is poorly explained and poorly understood, is we think a number of these people with resistant hypertension have an aldosterone excess, and that might be why spironolactone seems to be so useful for them. This is just showing you the adverse effect profile. Unsurprisingly, what you can see on the top graph is that spironolactone in the kind of pinky apricot-y color. Generally, people on spironolactone tend to have a higher serum potassium. Occasionally, people right out here heading up towards the critical range. And generally speaking, they've got a lower serum sodium. But actually, with spironolactone, it's relatively uncommon to see people with significantly low serum sodium levels. And so what we would generally recommend, like with starting an ACE inhibitor, you already got this person on an ACE inhibitor, it might be worth rechecking their serum potassium and their serum creatinine a few weeks after starting, just to make sure they're tolerating it. But they've used relatively standard dosing here for hypertension. 25 milligrams as an initial dose is a very reasonable place to start for spironolactone. In terms of the newer aldosterone inhibitors, so the non-steroidal inhibitors, mineralocorticoid inhibitors, we just don't have the data to suggest they're similarly effective. But hopefully that will come, and we can avoid some of the adverse effects of the off-target adverse effects of spironolactone. All right. So case 5. So this kind of segues into our AKI. So case 5 is CKD. So Mrs. OP, 78-year-old woman who has long-standing hypertension, diabetes, and coronary artery disease. She is hypertensive on 2-agent therapy and submaximal doses of both agents. Her GFR is 24 mils per minute. Bicarb is slightly low at 21. Potassium is within normal range. She has a UPCR of 110 milligram per millimole, which is about 1 gram per day, essentially. And so the approach here, we'll discuss the approach before we go to the considerations. The approach here is this is a 78-year-old woman who is hypertensive. The SPRINT trial suggests that this lady, that we know nothing else about her, would tolerate more aggressive blood pressure control. Overarchingly, though, her UPCR is a target for me to look at trying to reduce that. We have to balance this in a 78-year-old woman against what is her comorbid burden, what is her frailty, and what is her expected life, what is her life expectancy. So she'd be expected to live into her mid-80s in Australia, and because she's made it to 78, she's liable to potentially even go longer than that on average. And so she's still got potentially a reasonable amount of life left. And from my perspective, reducing the chance she needs dialysis in the future is actually a core target for her. GFR is 24. There's still GFR there to defend. And one of the most important things that we can do for that is to reduce her UPCR, reduce her proteinuria. And so my approach here would actually be to optimize her therapy further. And my first feeling would actually be to do that by targeting, by increasing the dose of everamipril, which will hopefully help her blood pressure, reducing her renal risk, her CKD kidney risk, even though she does have an increased risk of AKI, and also reducing her cardiovascular risk. The other thing is to think about with patients who are in stage 4 CKD is they've got more chance of dying from a heart attack than they do of actually developing end-stage renal failure requiring dialysis. So managing her cardiovascular risk factors are a major consideration here. And so the question, this is probably the one that comes to most in mind, and it's one I think about a lot as well, is just how aggressively should I treat my elderly patients? And so the literature suggests that the aggressive blood pressure targeting for elderly people, even those above the age of 80, has cardiovascular benefits. There is some literature that to suggest, and it's controversial, but there is some literature to suggest that there is an increased risk of significant fall. There's certainly an increased risk of syncope and postural hypertension, but in significant fall where people fracture, there is an increased risk probably there as well. And so we need to balance that against what type of elderly patient are you looking at? Are you looking at someone whose already blood pressure is a little bit low, or they've already got a bit of a systolic drop when they stand, or they've had recent falls in the past, or they're suffering from dementia? These ones might say, well, actually, this situation might say, well, actually, maybe I don't push as hard. But if they're a good 78-year-old, then actually maybe I go for that 120 on 80 if I can safely get there. In terms of the lowering the kidney risk in this person, as you aggressively control blood pressure, there is a potential increased risk of AKI. And so what I would do is this person should probably be getting 3 monthly blood tests monitoring their renal function anyway. And that's probably sufficient. I wouldn't change that. So who's most vulnerable to developing AKI? And it's a broad group of people. But when I think of the elderly, I think of those who have vascular disease, because what we often find is they already have very fluctuating baseline serum creatinine levels. People who have polypharmacy, and people who have CKD or a history of recurrent AKIs are probably those kind of key groups that I think about here as being a significant further risk. And is there anything you could recommend on managing sick days to prevent AKI? So I actually do try to spend a couple of minutes at the end of the consultations with patients like this to say, if you get sick and you have either high fevers, diarrhea, vomiting, you're unable to keep your fluid intake up, you do have an increased risk of AKI based on the CKD and the medications that are prescribed. And so what that really means is, for these guys, if they are unable to keep their fluid up or they're having high fevers, they're significantly unwell, they need to seek review early, whether that be with their general practitioner or through the emergency department. If they're unable to do that, that would be the reasonable first step. If they're unable to do that, then I actually suggest, whilst they're that sick, they withhold their ACE inhibitor, their SGLT2 inhibitor, their diuretic, and, well, generally speaking, I try and get them off the NSAIDs already, but if they're on NSAIDs, to withhold those as well. You can talk about withholding other things for people potentially with low blood pressure, but generally speaking, that's a reasonable, safe place to be in the first instance. Cool. And this is kind of coming onto that question about the ACE inhibitors and the double-edged sword. So for proteinuric kidney disease, they're fantastic. They're our first-line therapy, and that is because they reduce that glomerular filtration pressure, which is on the next slide. But they have this impact on cardiac remodeling, which is really important for our CKD population. And they also have benefit for people who have diabetes mellitus and microvascular disease, and also for people who have got coronary artery disease as well. The beauty of these is they don't have rebound hypertension. They've got a reasonably long half-life, and unlike things like centrally acting antihypertensives or some beta blockers, when you stop them, the risk of rebound hypertension is exceptionally low. And the reason that they are a risk of AKI, and we use them in CKD, is the same reason. So if this is your glomerulus and you've got your arterial inflow here through your afferent arteriole, your glomerulus, and your efferent flow, angiotensin 2 constricts the efferent arteriole. And so what that does is, by constricting here, it increases the pressure in the glomerulus, so increases filtration pressure. When we inhibit that vasoconstrictive effect, we reduce intraglomerular pressure, and that pressure across the glomerulus then drops. We get less filtration at the glomerulus, but we reduce the hyperfiltration, which is actually a core part of diseases like diabetic nephropathy. And that's why overall, these people do better in the longer term. And it's the same reason why SGLT2 inhibitors are probably so effective as well, is that they also reduce intraglomerular pressure by a different mechanism. And so that means that actually, even though in the short term there's some risk, we have to manage that. In the long term, they are excellent. And where are we now in terms of time? So I'll just quickly move through AKI. My approach to AKI is essentially still the medical school approach to AKI, which is, this is broken down to the pre-renal, intra-renal, and post-renal. Post-renal is generally the realm of the urologists, so I'm not going to delve into that much today. We'll do a bit of pre-renal stuff. So pre-renal is where the blood flow into the kidney is reduced, and that can be from intraglomerular hypovolemia, so renal losses, GIT losses, someone who's hemorrhaged or someone who's third spaced, or reduced effective circulating volume. So someone who's got reduced cardiac output, or they're vasodilated, or in the rare case where they've got hepatorenal syndrome. And so both of these situations mean that the pressure reaching the kidney is not low enough to maintain normal, it's not high enough to maintain normal glomerular filtration pressure. And generally speaking, these are all readily manageable. Depends on what your reduced cardiac output is caused by, and your hepatorenal syndrome is a little bit more tricky. But generally, these other things we can manage. Intrarenal causes is really where we earn our money, and so this is where we're talking about something impacting the nephron from the glomerulus all the way through the tubules. And so when we look at the nephron, we can have things affecting the glomerulus like glomerulonephritis, or vascular injuries affecting the glomerulus, directly affecting that filtration membrane. But we can also have things that affect the tubules. So acute tubular necrosis at the bottom there is more of a toxic effect. So this is what we see with aminoglycosides and non-steroidals. So they're causing toxic damage to the kidney, or in someone who has a cardiac arrest and they underperfuse their kidney. Acute interstitial nephritis is more interesting. That is essentially an allergic autoimmune response in the kidney tubules, and that can be driven by drugs or autoimmune diseases or infections. And so acute interstitial nephritis is readily manageable with immunosuppression, and acute tubular necrosis is managed conservatively. And so the approach to this in terms of workup, the basic things that we do for everyone, even those who are high risk, whether they're in terms of their stage of AKI, is we discontinue nephrotoxic agents where that makes sense. So for the high risk person who needs antiproteinuric therapy, we wouldn't stop their ramipril. We manage their volume state. We don't generally manage hemodynamic monitoring because that's more of an ICU thing. We monitor their serum creatinine, and that can be done in the community too. Urine output in hospital, but not in the community. We manage their blood sugars. We don't give them a radio contrast load unless we require it. And then the other things we need to looking at their blood tests, doing a urinalysis to identify whether they might be proteinuric or have an active sediment, and then potentially look at some of those things down the line that really are sort of hospital management issues. And so which medications do we withhold in AKI? The guidelines for this are very variable, and they're definitely not complete. So if you have someone who develops an AKI, one of the things we can do is we can take away things that cause ATN, like non-steroidal anti-inflammatory drugs, for example. We need to take away drugs that will accumulate. So metformin is actually one of these, which is actually not a nephrotoxin. It's often called a nephrotoxin, but it's not nephrotoxic. It's simply that if with reduced kidney function, it accumulates, and then we get that toxicity of metformin. So we're protecting the person from the toxicity of the drug, not protecting their kidneys from the drug. And then there's that group of drugs that we most commonly withhold, those that alter renal physiology. So that's our ACEs and our ARBs, which are going to be changing intraglomerular filtration pressure. SGLT2 inhibitors should be on there as well. And then diuretics and non-steroidals as well, because they all change glomerular hemodynamics in a way that potentially could impact our GFR. Interestingly, for the future, there's conflicting data around maybe whether ACEs and ARBs are something we should be withholding, but at the moment, the safest thing to do is to definitely withhold them. And then there's a whole lot of things that can cause AIN, everything through from your beta-lactams to your non-steroidals to your proton pump inhibitors. but also things that alter electrolytes. So particularly we're worried about potassium in these cases. So your spironolactones, for example, would be withheld too. And then in terms of drug adjustment, the short answer here is that we don't have a good way to guide this. We can't rely on the GFR in acute kidney injury because it's a meaningless number until the serum creatinine is at steady state. So we just have to simply make an assessment of what their kidney function is based on the rate of rise on serum creatinine, and try and do the safest thing in terms of drug dose reduction. And hopefully it's a short-lived process, in which case then we can go back to standard dosing as their kidney function improves. And so the questions here to consider: what are the early warning signs that AKI might be developing or evolving? And sadly, the answer is really there aren't any. AKI in the early phases is almost universally asymptomatic unless there's an underlying cause that we can identify. If someone's got a obstructed bladder, for example, then they're going to have lower urinary tract symptoms and probably suprapubic pain, for example. If they've got an autoimmune glomerulonephritis, they might have hematuria that may even be visible. They might have extrarenal manifestations of the disease as well. But generally speaking, for most people, actually, they find out they've had an AKI when they get their blood test done. And so when should someone be referred to hospital? So if someone has had a rise in serum creatinine that's sort of 50 to 100% of baseline, potentially that could be managed in the community. Anything above that really should come in. The other thing that should come in is where we think there's a potentially a reversible cause that's going to require specialist input. So if we're worried this person has GN, then coming into hospital so we can get on top of that early, probably get a renal biopsy done, and early start to therapy is beneficial. If they've got an obstructed urinary system as well, same deal. The other side of it, though, is if they've got a clear explanation for why they've had this sort of moderate rise in serum creatinine, they've had a lot of diarrhea, they've been dehydrated, and that's now resolved, that might be something where we could, simply sit on that, withdraw the appropriate drugs, and rehydrate. And then how often should you monitor? This kind of relates to how severe the injury is and how close they are to baseline. So we discharge people from hospital at a range of different points, but generally speaking, if it's an AKI and we're happy they're safe to go home, their serum creatinine has progressively fallen by significant increments, even though it may not be back to normal. If it's not back to normal, it probably should be tested again within a week or two. My feeling is generally within a week of discharge. If it's returned to baseline, then I'd still probably check it again within a month and then just go back to standard monitoring based on whether they have CKD or not. But it becomes a bit of nuance here, because if you've had one AKI, your risk of having another one increases. And that's a combination of factors, maybe the underlying disease process, but also that maybe you've actually got reduced renal reserve, which is that amount of kidney function that we can't measure on routine testing. Sorry, I sort of blitzed through at the end there. I was running a bit over time.
Well done. You've done very well, Tom. You've actually answered most of the questions that I put to you, which is fantastic. You've already done that. So whilst we're just waiting for a couple of questions to come up, there is one question that has come up. I got a little bit, blurry-eyed when you were talking about glomerular.
That's a normal response.
But somebody asked, Ash asked, why glomerular apparatus filtration reduces in hepatorenal syndrome.
Yeah, so hepatorenal syndrome is an interesting condition. So essentially what it is that there's a change in the how the liver handles sort of vasoactive agents. And so those vasoactive agents, which would normally be which come from the gut, which would normally be destroyed in the liver, actually enter the circulation. You get splanchnic vasodilation as well. Mm-hmm. So they actually have huge vasodilation intra-abdominally, and actually their overall effective circulating volume drops, because essentially they've got such significant vasodilation that their venous return to the heart drops off and their cardiac output reduces. And so hepatorenal syndrome, if you biopsy the kidney of someone who's got hepatorenal syndrome, it looks completely normal, generally speaking. If they've really underperfused it because their blood pressure's really dropped, then you might see a bit of acute tubular necrosis from the ischemic injury. But actually it's an issue in terms of perfusion of the the kidneys themselves.
Mm-hmm.
And it can be really quite difficult to manage. Actually, it's when it's a chronic form, it actually is a really significant impediment to outcome.
Mm-hmm. Okay. And then I wanted to ask a question around intravenous contrast. So we do order a lot of imaging, and CT imaging often does have contrast. What do we as GPs need to tell our patients and consider when we are ordering tests? Should we be asking for non-contrast imaging? Whose decision is it, and how do we get around that?
It's a really good question.
Yeah.
And it's complicated as well, because the data around contrast nephropathy, the more you delve into it, is increasingly weak, especially with newer agents. So the risk actually absolutely is still probably low. My approach to this is, if the person needs the test because it's important for a health outcome, the obvious one is the person with appendicitis. If they've got a GFR of 9, they've got appendicitis, they need the contrast scan because they need to have the operation. I think that's a relatively straightforward one. If you're looking at a vascular issue that's going to potentially be life or organ threatening, or important for the person's overall health outcomes, that obviously makes sense too. Where possible, I suggest using a non-contrast scan. So, for example, all sort of CT KUBs generally non-contrast, so that's easy. But then there's that huge gray zone in the middle where, if you're talking about someone who's getting an abdominal CT scan, for example, if you don't have contrast, you're probably going to miss the diagnosis or have to do a follow-up study anyway. And then there's the radiation exposure. So I counsel the patients, and I simply say, look, this is an important test because we're trying to exclude X, Y, Z, and that has implications for your health. The contrast that they'll give you does come with a risk of kidney damage. With that kidney damage, often it's temporary. And so, generally speaking, your kidney function will come back to normal. If it's not temporary, it could potentially stay like that, but that's exceptionally rare. And generally speaking, when I'm talking to someone in hospital about that, because we often get a consult to say, we want to contrast, what do you do? Generally speaking, I say, look, worst case scenario, and it's not a great outcome, and your kidney function drops significantly, then we offer you dialysis. But if you're talking about someone who's got sort of stage 3, 2-3 CKD, the chance of having a really significant AKI is quite low.
Okay, so a GFR of what?
More than 30.
More than 30.
Yeah.
They're pretty safe with contrast.
Yeah. I'd still warn them, but I would feel comfortable.
Yeah. And do you tell people to load with fluids? What do you tell them? How do you tell them to manage fluids in that period after having contrast? Yeah. Yeah.
So, especially in the sort of the ambulatory setting. So when I see people in clinic, which probably is the most carryover, it's if they're in hospital, we give them a litre of saline pre, and then we do it again afterwards, presuming there's no fluid restriction. If there's no fluid restriction, I'd simply tell them to hydrate well on the day. So 500 to a litre before they've gone in. Get the scan done, and then make sure they're maintaining hydration through the day. If there's something that happens where they're unable to maintain that, then, for example, they get sick, be relatively unlikely, I guess. But if that were to happen, that they get seen. Okay. Yeah.
So a couple of other questions coming through. So we have one from MED. Anyway, how long after starting an ACE inhibitor or ARB do we check the renal function and serum potassium? That's a good question.
It is a good question. Yeah. And so for this, the recommendations are within 1 to 2 weeks. I generally sort of do it around the week mark. Most of these, because really what you're waiting to see is the maximal effect of the drug. And the steady for most of these drugs, they'll probably hit steady state concentration at about 5 days from either a dose increase or the addition of the new drug for an ACE inhibitor or an ARB. And so a week or 2, but generally for me, I go for a week, because I think at that point you're going to see maximal effect on serum potassium. And if there's someone who's predisposed to having an issue, like many of the diabetic patients have an underlying condition of their tubers where they are more prone to getting hypokalemic, then you'll see that and you can back it off sooner.
Okay. And what if they drop their GFR?
Well, it depends how much they drop it. That's the short answer. So this is actually really important for us. So when we start an ACE inhibitor or an ARB or an SGLT2 inhibitor, for example, we actually do expect that GFR to come down slightly. And so the suggestion is that up to 10% is probably within the limits of with an ACE inhibitor and ARB, an SGLT2 inhibitor, you might potentially be looking at up to 20%. If it's more than 25%, then I'll stop it. I'm actually starting to think, is there something else here that I'm missing? Does this person potentially have, bilateral renal artery stenosis?
Yeah.
I've put them on an ARB, and maybe it wasn't the right choice.
Yeah.
So then I'll stop and reassess.
About 25%.
Yeah.
Yeah. Drop. Okay. So somebody, Ash wants to know how to risk stratify the risk of elective coronary angiograms in CKD stage 3 to 4 kind of patients, and how to weigh it out. Your golden words, please.
I don't know if I've got any golden ones. So we get these consults all the time from cardiology, and because it's a difficult question. So with coronary angiography, there's two risks. The minor risk is the contrast, which is probably still relatively low. The problem is this risk of atheroembolism, where unfortunately as they're entering the arterial system, some cholesterol debris can be knocked off the vessel and then downstream land in the kidneys, and that can actually cause a really severe AKI. The risk of that, absolutely speaking, in terms of you look at the number of coronary angiograms people have, is relatively low. And so for me, actually, I find this question when we're looking at it, it depends why we're doing the angiogram. So if we're doing the angiogram because they're post on STEMI or STEMI, it's an obvious. Well, I mean, STEMI, they should be getting it anyway, but post on STEMI makes obvious sense. What we're looking at there is potentially stenting a coronary vessel, which will prevent them having a heart attack down the track, which is actually for our renal patients the major cause of death. So from that side of things are obvious. If it's a questionable study, which to be honest, I don't think the cardiologists really do many of those, then you can say, well, what's the material benefit we're expecting to do from the study? I think even for someone where they're going to be doing angiogram to say, look, they're having what we think is unstable angina, even then I actually think the risks are outweighed by the benefits. Because if you're finding someone who's got unstable coronary plaque and you can diagnose it, intervene on it potentially, then that's a win. So it's about risk management for me. So I would say to them, look, your heart is really important. You can actually live without your kidneys for a good long while, albeit reduced quality of life with dialysis, but you can't live without your heart. And so in that setting, I think we need to control that cardiovascular risk. We can do everything that they will manage your kidney risk as best they can around that, because essentially what will happen is they'll have their ACE inhibitors and ARBs, SGLT2 inhibitors withheld, they'll be pre-hydrated, all the key things will be done to minimize that risk, and then it's all about the benefit.
Yeah, that makes sense. Okay, so I just are there any more questions there? Oh, there's a few questions. Can they do low dose contrast angiograms? I don't know.
Yes. So that's that is something that is offered by a lot of radiology services. So the idea that you're getting this sort of lower load of contrast. So one of the things with contrast used to be it causes renal artery vasoconstriction. So with less of it, theoretically, you get probably less of that too. There's probably an element of this that's idiopathic if it's there, and so it may not necessarily change with that. But the lower dose of contrast they can get away with, the better. And it's simply then the radiologist balancing what's the risk of doing a study and not being able to get the answer with the low contrast load versus doing it with the upper contrast load. If they can safely do it with the lower load, then always for that.
Okay, so I might just.
And I see one there.
What's
NAC is out of the window, right? It is at the moment.
What is NAC?
N-acetylcysteine.
Oh,
so
okay.
yeah. So we used to recommend N-acetylcysteine for prevention of contrast nephropathy, but the data around it is essentially non-existent. It doesn't appear to be beneficial. It's also probably exceptionally low risk. But I don't even know where you get it these days anymore, if I'm honest. But
Gosh, I'm just being daft. What is it again? I've forgotten.
So it's what we use an acetylcysteine for paracetamol poisoning, actually.
Okay. Yeah, that's right.
Yeah, but it was supposed to be thought to be a sort of scavenger of free radicals or something like that.
Yeah.
Unfortunately, it didn't do much.
So somebody has just asked a question. It was actually a question I was going to ask you as well. Coming back to hypertension. So what about white white coat hypertension, if the patient has markedly different blood pressure, self-monitored, or the 24-hour monitoring at home, but then in the GP office it's high, what do we do? What do we treat? Does it modify target, BPs, and do you need to do any additional investigations? I do find this really challenging. This is really hard because we see these patients in the rooms time after time, and their blood pressure can be really high, like 180 on 100. And then they go home, they do their monitoring, and they say it's 120 on 70. And their 24-hour monitoring often comes back okay as well.
I think that's kind of the one of the key things for me is if they're going home and doing it themselves, I'm going to get really paranoid about that, because when it's 180, that's you're talking about really high numbers, and you think, how do you go from being 120 systolic ish to 180 just by sitting in the room?
I've done it.
It obviously can happen, but I worry about those people on two levels. One, I worry about, am I missing actual hypertension? And so the 24-hour ambulatory blood pressure monitor is key in that setting, has to be done. If it's completely normal, I'm going to be really suspicious about that. But that's what I'm going to base my decision making on in the first instance. But what I'm probably going to do is get them to repeat that 3 to 6 months as follow-up, because I'm looking at that person with that blood pressure in clinic and saying, okay, well, over 24 hours, your blood pressure is fine. And that's wonderful, because your average blood pressure really is the key predictor of cardiovascular risk. But if your systolic's that high here, you're going to be hypertensive at some point, or have I missed it? So what it would do, I wouldn't actually start treating that blood pressure if I've got a really reliable 24-hour ambulatory blood pressure monitor result. But then I would monitor with the ambulatory blood pressure monitoring, and I would be very paranoid about that person.
Okay, that's probably the approach that I have. What about are all the class medications equal? So is there any point, if somebody's on ramipril, switching them to a different ACE?
No, there's not. So we don't have evidence that any of the ACEs or any of the groups are ACEs, ARBs, or even switching between beta blockers, for example, as long as they're sort of same class of beta blocker. No seems to be a class effect for sort of most things. Some of the beta blockers is a bit trickier because some of them have sort of effects on vascular tone as well as cardiovascular parameters. So they might have different blood pressure effects, and you might use them in different circumstances. But generally speaking, indapamide, hydrochlorothiazide, clothalidone, all the same.
So just pick the one you like and just stick with it?
For me, I pick one where it's got a good dosing interval. So one I can start low if I need to, but I also got a lot of escalation potential.
So ramipril.
I like ramipril. I like candesartan too for that reason.
Okay. And fixed dose preparations, what do you think of them?
I think they're really useful. I think it's one you've got to have ones that you're comfortable with, and you've got to start working towards them. So essentially, what fixed dose combination you might end up using down the track, and start with the single agent for one of those, and then add in the second agent, make sure they tolerate it, and then combine it.
Perfect. Okay, what is the age cutoff point to start investigating secondary hypertension?
Strictly, there really isn't one, and then the reason for that is one of the core causes that we need to consider is renovascular disease, which can happen, which increasingly happens in males, particularly as you get older. So we need to keep that up our sleeves. So people who aren't responding, for example, to someone who's got resistant hypertension, and they've previously actually not had significant hypertension, they got through their 40s, their 50s, their 60s, not had issues, and now suddenly they're difficult to manage. Then we would also start considering that person as someone we need to start looking at secondary causes for. Things like Conn syndrome and pheochromocytomas, generally speaking, you're talking about a younger cohort of people. Anyway, Cushing's syndrome has a large number of causes. So, if you're starting to see features that suggest, maybe their blood sugars are suddenly up as well, and their blood pressure's up, and they're looking a bit Cushingoid, then I would start to move down that route. So there's no strict age cutoff, but there's definitely in those younger people, less than 40, they really need to be investigated.
Okay. Another couple of questions. Is it better to take blood pressure medication at night and which ones are better taken this way.
Yeah. So
I sometimes split the medications. Is that stupid to do?
That's a really good approach, actually.
Yeah.
So I always start, when I start single agent therapy, I start it at night. The rationale there being that first dose effect for those first few doses of most antihypertensives, the risk of postural hypertension is higher. If it happens at night, hopefully they're asleep. So, but then if I start a second agent, there's actually evidence if you split that one agent in the morning, one agent at night, overall you get better blood pressure control. So then I would shift the second one to the morning, especially if it was, for example, a diuretic.
Okay.
Yeah.
And somebody asked, which ARB or ACE do you consider as more efficacious?
They're all the same.
So all the same.
Yeah.
Ooh, battery's running
so
low.
You just pick the one you like is my approach.
Yeah. Okay. I recall a renal specialist indicating that ramipril may be less efficacious, but telmisartan may be more effective. Is that true?
No, we don't really have evidence to suggest that. Certainly, not broadly speaking. So no, any ACE or ARB is probably as good as any other. Yeah.
And then Ash really makes a comment. I believe white coat hypertension patients have high adrenaline triggers in general, whether it's white coat or any other day-to-day life activities. So they have probably high risk underlying. Yeah. I sort of think that too.
Yes.
Yeah.
And I think that's where what the data suggests as well is that, these guys do have this sort of underlying issue. So the white coat hypertension is a manifestation of the underlying physiological problem, which means they're more likely to have hypertension in the future. They're more and even just from a white coat hypertension perspective, have an increased risk of cardiovascular disease secondary to someone who's genuinely non-hypertensive.
I was just going to try and stop sharing, but I just failed. Sorry, everybody. Anyway,
okay.
never mind.
Maybe
Kunal already did that. Anyway. Well, I think that brings us to the end of our questions. I think, Tom, that was really good. Thank you so much for presenting that. I hope everybody found that a very useful topic. I certainly learned lots of things. Whilst I did know that all those lifestyle measures were so important, it was really good to hear again how important that is and how much more we can be doing in that regard. And it's reassuring too to think that my approach is reasonably sound.
It's pretty good to
me. Somebody wants to know where you practice in the ACT.
Canberra Hospital at the moment.
Hospital. Yeah. So anyway, that brings us to the end of our session. We're just 2 minutes short of 8 o'clock, so we've done really well with time. Thank you, Tom, for coming and presenting, and thank you to the Capital Health Network team who helped with the IT for this evening. We've really enjoyed presenting this, and we hope to see you again at the end of May when we're going to be doing another one of these about CKD. Fantastic.
Be awesome.
Thanks, everybody. Good night.
Thank you.